Just to repeat the announcement while we're getting ready for the Kim's booth. I don't know if you've been to it, if you managed to do the CME registration, but this is a good chance for you to go there and have it done, because to have your CME counted, you need to actually do it online now. It will not be accepted just by paper. It has to be online, and it will be a chance for you to get help from them. They can just do it to you while you're here in the conference. Just visit their booth, please. It's a much easier process. At lunchtime, of course, not now.
The housekeeping is important. Thank you. That was an excellent review by Dr. Noella Lucas. I'm just going to carry on and talk about the maternal valvular diseases. The objectives is for me to review some of the physiological changes that the previous speaker touched on already a little bit, and understand the data that we have, which is actually quite unfortunate, not as robust as we would like them to be, and talk about some of the principles of management. So, the previous speaker already alluded a little bit to the changes in both the hemodynamics and some of the physiological changes during pregnancy. So what you see in front of you on the slide is talking the top line, the blue line is the cardiac output. So the x-axis is obviously the gestational weeks, and you see an increase easily from 35 to 40% during the gestation of cardiac output. At the same time, you see the mean arterial pressure initially dips a little bit, and then it sort of maintains back to normal. More importantly, you see the systemic vascular resistance just drops right down during the whole gestation period. This has been well studied, so it's useful for us to see that as what we would use as a standard to gauge as the normal pregnancy. The total blood volume also goes up. The plasma volume goes up. The red cell volume does go up, as you can see in the bottom green line during the gestation, but it doesn't go up as much. So that's why you see some of the hemoglobin dropping during the pregnancy, and the anemia starts to manifest itself. We also know that there are valvular regurgitation, which is normal in normal pregnancy. This is one study. There are several studies out there. You can look them up yourself on PubMed or Google search nowadays. There are 5 periods that this study's looked at, between 8 to 14 weeks, between 20 to 24 weeks, between 30 and 34 weeks, 36 to 40 weeks, and then 3 to 6 weeks postpartum. And what you see here is the 5 time periods, T1, T2, T3, T4, T5, and you also see the percentage of patients with regurgitation, the valvular regurgitation, and you see that the black bars are mitral valve regurgitation, the gray bars are tricuspid, thank you. My glasses not quite reading it. And then you see the pulmonic, and so this is normal that you would see during pregnancy. So we have to bear that in mind when we are managing patients with valvular disease. There are a lot of case series out there, and these are a series of cases, an individual center or a group of centers coming together, and then they do a case cohort studies matching the cases to controls, and then looking at outcomes and management principles. Very few actual large database out there, and the European Registry on Pregnancy and Heart Disease is one that is out there, short form ROPAC. And they looked at they looked at all the registry of cardiac diseases during pregnancy, and congenital heart disease certainly comes up the highest, and then the valvular heart disease, cardiomyopathy, ischemic heart disease. However, if you actually look at the distinction or the difference between developed countries versus developing countries, the proportion flips. So in countries such as OECD countries, the incidence of rheumatic heart disease has dropped significantly over the last decades. But in many of the other countries, rheumatic heart disease remains very high. I don't know the statistics in Kuwait, so I don't know where Kuwait stands. But one of the challenges we have is we don't have good databases worldwide to look at how the disease process is changing in different regions. We do know that rheumatic heart disease remains very high, and it's the main cause of valvular heart disease during pregnancy outside of OECD countries. I'm not going to talk about congenital heart disease today, because in 20 minutes there's only so much we can touch on. But this is just to show you that in congenital heart disease, some of the complications are a little bit different from rheumatic heart disease. And there are a number of bars, so it could be quite difficult to discern. But if you look towards your right, you will see the Eisenmenger disease or syndrome, and from there you actually have cardiovascular complications, which includes MI, CVA, and mortality. So what you actually are looking at from Eisenmenger's, from congenital heart disease, these are patients born with congenital heart disease. Because of the improvement in management and various corrective surgeries, these patients grow older. Now they become pregnant, and they come with cardiac problems because of their congenital heart disease, corrected or otherwise. And Eisenmenger being one of the results of that, and they have complications, and their complications are somewhat different from rheumatic heart disease. Heart failure remains one of the most common complications from both rheumatic heart disease, valvular heart disease during pregnancy, and in congenital heart disease. And you can see that there are actually kind of three periods. X-axis is, of course, the gestation weeks, and the y-axis is the incidence. And between 25 to 30 weeks, you see the peak sort of right in the middle of the graph. That's one peak, and there's the blue bar, that's during the time of delivery, and we have the turquoise bar, which is in the postpartum period. So there are three periods that we actually see patients going into heart failure. And most of that is because the increased preload and heart rate, and that leads to the heart failure. And in the ROPAC data, median time is 31 weeks in all groups combined, but in mitral stenosis, the incidence is about 31%, but it peaks at 25 weeks for mitral stenosis. Maternal mortality, 4.8% in patients who develop congestive heart failure, and 0.5% without. So it is a very distinguishing feature if somebody starts to develop congestive heart failure. The complications from valvular heart disease, definitely you have congestive heart failure, you have arrhythmia. Most of the arrhythmia is atrial fibrillation. And because of the rheumatic valvular disease, the patients usually need the atrial kick. And if they go into atrial fibrillation, things actually really get much worse. There are fetal complications. Most common is the premature labor, but there is IUGR. And there is mortality. Mortality is about 1.7% in the ROPAC data. 60% or so of those, they actually couldn't determine the cause. And then 21% clearly due to maternal condition. So it's usually poor cardiac output, congestive heart failure, oxygen desaturation. The general principles really comes down to if the patient has mild, severe, or moderate mitral stenosis, valvular heart disease. And certainly in most cases, and for sure in moderate and severe cases, it has to be a multidisciplinary team. And obstetrician, cardiologist, and anesthesiologist or anesthetist need to be involved early on so that everybody is on the same page. There certainly is an argument to be made if it's moderate and especially severe, and some of the criteria are being outlined below. If we have a patient who is pregnant, there may be a need to discuss whether a termination is a wiser course. And some of those conditions will be already, the patient has had prior cardiac event or arrhythmia. New York Heart Association 2 or greater than 2, so 3 or greater, or already have cyanosis, central cyanosis. Ejection fraction is less than 40%, pulmonary hypertension, severe aortic stenosis or severe mitral stenosis, and severe AI or mitral regurg, and their function capacity at the New York Heart Association 3 or 4. So you have somebody like that, early on in the pregnancy, you know things are going to get worse, and there's a big question is whether we should even try to carry on with the pregnancy. If the decision is to carry on with the pregnancy, the general principle is to avoid cardiac surgery if at all possible. And this is in the case where you have to go back in and actually either fix the valve, repair the valve, do whatever. And most of that is because the risk to the fetus, because if you made the decision to save the baby, then if you go in before the second trimester, very, very high teratogenicity as well as abortion rate. If it is a stenotic valve, balloon valvulotomy is always possible and should be thought about if things start to go wrong. If a prosthetic valve is present, and this is in case someone who's already had previous corrective surgery, then thrombosis or hematology need to be involved because your anti-thrombotic agents need to be considered and followed up. And rate control with beta blockers has to be considered early on as well. During labor, this is more or less, again, alluded to by the previous speaker, that we see the red line, which is what happens to the cardiac output during contractions. And even between contractions, we see that the the cardiac output rather, starts to go up. And you can see on the x-axis, time 0 is the time of delivery. And you can see at that point, the cardiac output really goes up. So if we have someone who's already on the verge of heart failure or decompensation, this is the real stress test that's going to come. So we have to anticipate that. During the labor, if in the case of a moderate or severe valvular disease, say mitral stenosis being the most common one, really there should be very close hemodynamic monitoring. I think one of the things that I was not able to find a lot of information on is echocardiography. Definitely that's been the new tool we have in our armamentarium, and publications surrounding echocardiography and the time of labor has been somewhat paused. Nevertheless, we used it to guide our management when we had these cases. And it really has changed our management principles. And in most review papers as well as textbooks, and certainly in our teaching, we would suggest that a vaginal delivery with some sort of epidural analgesia without pushing, because with the Valsalva, we will change the preload, afterload relationship, and that's probably going to precipitate some sort of either arrhythmia or worsening heart failure situation. That's has been the traditional recommendation. It's been given probably for decades now. And all I would say is don't be rigid. We really have to see case by case what the right decision is. I've already mentioned the at-risk period. It's towards the end of stage 2 labor and immediately postpartum. And I'm talking about like 20 minutes, within the 20 minutes of the postpartum period. And they are also at risk postpartum for up to 24 hours. I just want to illustrate a case, with a case, 31-year-old gravida 1 at term for delivery due to symptomatic rheumatic mitral valve stenosis and regurgitation, and she was already in heart failure. Now, the recommendation of doing the vaginal delivery and epidural would have worked probably, except she couldn't lie flat, and she was already in heart failure, and she was becoming increasingly symptomatic as the labor continued. The mitral stenosis previously was described moderate to severe. Unfortunately, she refused valvulotomy during the second trimester because of the potential radiation exposure. And she was still in normal sinus rhythm, which was a good thing. And so I would maybe ask how people would feel given this kind of scenario. How many people would go for vaginal delivery? Can I see a show of hands? With an epidural, so I see a few. And how about just go straight for C-section and not, with the epidural? And many are not quite sure.
Combine spinal epidural with cesarean section.
For those who didn't hear, the combined spinal epidural with combined spinal epidural for cesarean section was the suggestion up here. So after much discussion between the patient, the anesthetist, and the obstetrician, now I have to give the context. We've managed a few of these cases, and one of the first cases, which is not this case, in fact, we had to put the patient to sleep because the patient could not even sitting up, she was short of breath. She was severe mitral stenosis in pulmonary edema. So we had to put her to sleep. When the patient was induced, she immediately went into rapid atrial fib, and we actually asked the obstetrician to do the cardioversion, who promptly decompensated in front of us. So we had to do the cardioversion ourselves. And we got the patient back, and at the end of the case, patient did fine, baby did fine. So the obstetrician at this point actually really trust us, because we've already had a prior history of successfully managing these cases. So after much discussion, we actually elected to, it wasn't my case, so I want to be clear, and we elected to do cesarean section under general in this case. Yeah. So what ended up happening was with the general, we were able to monitor the cardiac function with the TEE all through the case. That was one of the advantages of the general. Can I have video 3, please? So this is the mitral valve. You can see the left ventricle towards the bottom and the left atrium towards the top. And you can see this patient does have mitral stenosis with the turbulence coming into the left ventricle and a fairly significant mitral regurgitation going back into the left atrium. Can I have video 4? And this is after delivery, and you can see, in fact, there's less of a mitral regurgitation, and it may be harder for you to see, but the turbulence for the mitral stenosis is actually less as well. Thank you. If I can have the slides, yeah. And of course, we also did the measurements. So this is before delivery. So after the induction of general anesthesia with the TEE, we did the measurement, and at that point, the transvalvular flow is about 240, 300 there. And so we can see that it is a stenotic valve. For those of you familiar with transmitral valve calculation. And we also did a prepartum left ventricular end diastolic volume calculation, and ejection fraction at that time was 43% after the induction of general anesthesia. LVEDB was 90 mils, which was pretty good. And this is the postpartum, and you can see the jet actually has increased. So we're witnessing an improved flow after delivery across the valve. And the ejection fraction actually went up. Now we anticipate it to go up, but it actually did go up. And the end diastolic volume was reduced because the ventricle was able to empty better. So we were actually pleasantly surprised, but this is not the first time we've seen it. And we are now actually trying to collect a series of cases, because what we're seeing now is, in spite of what we know, this is well measured, during the time of delivery, we are seeing improvement of mitral stenosis flow pattern across the left ventricle and the left atrium and the left ventricle just at the time of the delivery and after the delivery. This is in C-section. Now, we were kind of forced into a corner because the patient was short of breath, couldn't lie flat, and so we had to elect to go with the C-section. And you can see in this graph, this was from previous studies, looking at what happens to the stroke index and heart rate. You can see the panel as we're coming down, and you can probably read it better than mine because my glasses are not actually focusing it that well. Mean arterial pressure, the cardiac index rather, the third panel, mean arterial pressure, and the systemic vascular resistance index. So what you're seeing is we see the rise in the cardiac index, we see the rise in the stroke index, and then we see the drop in the SVRI. That is well studied in normal pregnancy, normal cesarean section delivery, but when we actually apply this graph to someone who has severe mitral stenosis, what we are actually finding that with the cesarean section, the flow pattern improved, whether it's because of the drop in the volume, whether it was a drop in the SVRI. We haven't quite all figured it out, but what we are suggesting to you is, one, don't be rigid, and two, monitoring the echo may well be bringing us a new set of understanding around the time of this management. So, in summary, most of the OECD countries right now, the cause is congenital heart disease for patients coming with heart disease during pregnancy. But most of the non-OECD countries, the cause is rheumatic heart disease, and mitral stenosis being the most common. Now, for the sake of time, I did not go into all the other causes of cardiac diseases. We've had to manage Marfan syndrome. We've had to manage, because then we have the aortic insufficiency, we've had to manage coarctation. Those we're not, I'm not touching it because of the time. And we touched on the risk period is 27 to 28 weeks when patients go into heart failure and immediately postpartum. And the complications that we see during those times would be the heart failure and or atrial fibrillation. And team care is crucial. So if you have such a case, don't try to manage yourself and think that this is easy for yourself. And I would also put it out there, make sure within your department, the people who are experienced in dealing with this sort of cases be involved. You can disseminate the expertise, but don't try and rediscover the wheel on your own. Hemodynamic monitoring, epidural and vaginal delivery, those are the I guess the safest recommendation out there. There are circumstances that we get cornered, as this case that I present to you, a patient who cannot lie flat and we knew could not labor any further, and we risk running into problems, so we actually went for C-section. And in that case, we did the general anesthetic with a C-section. I would also say very likely with the epidural, it would be just as well, but it would be a bit more challenging to monitor the echo unless you're well versed with transthoracic echo. And the C-section changes in the SVRI and the blood loss, at this point we think may be advantageous, but it's too early for me to really give you a strong recommendation here. And overall, the data is still very, very weak. There are good registries out there, and we're starting to understand more the incidence and the prevalence and the incidence of complications. And the challenge has been, by and large, you're looking at significantly less than 1% of our delivery volume. That's why we continue to try and figure out what is the right thing to do. Thank you.
Our third topic by Dr. Anola again, please. Management of the partner with cardiac disease. Then we'll have the questions for our guest. At the end, then we'll have the physio control lecture after the discussion.
Thank you. So I'm going to be talking about overall general management of the part with cardiac disease, and I'm going to hopefully reinforce some of the messages we've just heard from Professor Yang. Now, cardiac changes during pregnancy, I don't want to dwell on this too long. Professor Yang described this very eloquently, but just to go through it very briefly, massive physiological changes in pregnancy, and these, by the time you get to the third trimester, in particular labour, these can become even greater. And labour and the time of delivery is a really significant risk period for any woman with cardiac disease. Now, cardiac disease is difficult really to describe and study for all of us because it's an extremely heterogeneous group of patients. Cardiac disease can arise from congenital or acquired problems. You can have a woman who's presenting with a repaired or an unrepaired problem. You can have structural lesions related to the plumbing of the heart, or it can be valvular lesions, as we've just heard about. And also there can be electrophysiological problems. And often, cardiac problems go with syndromes that pose other problems for the anaesthetist, such as Marfan's or Ehlers-Danlos. So to study these patients is very difficult, and this is one of our first difficulties alluded to by my colleague, the previous speaker. published research for individual conditions is very, very limited. We have very small numbers, very small case reports and case series, and at best, we could really say it was level C evidence. The major points of reference that I'm going to be using are the CARPREG study. It's quite old now, about 15 years older, a series from Canada of around about 1,000 patients, the heterogeneous group of patients, as I've mentioned. I'm also going to be talking a little bit about the UK maternal death inquiries. I would urge you to take a look at the European Cardiology Society guidelines in this area, and I'm going to mention ROPAC. Now, first of all, ROPAC, the previous speaker did mention this, the Registry of Pregnancy and Cardiac Disease. Now, this is an international collaboration led by the European Society of Cardiology, and they really want to try and accumulate as much data as possible on women presenting with a variety of cardiac disorders to really improve our knowledge and understanding in this area. And we've started to see some important publications emerging from this registry, and I'll mention at least one of these later on. The European Society of Cardiology guidelines in this area is a huge document. I think it's about 50 pages long. But if you want to just have something as a quick reference to have maybe available on your labour wards, this is the essential messages summary, which is a much shorter document and really précises very nicely what the entire document says. And I have to say, I think I found that a little bit more readable than the whole document. Now, I mentioned the maternal confidential death inquiry, so this is called EMBRACE, which stands for Mothers and Babies, Reducing Risks Through Audit and Confidential Inquiry. Now, this is a series of reports that's been running in the UK from the mid-1950s. Reports used to be published every 3 years, but they're now published annually, and they look at maternal mortality from all causes. The most recent report was published on Wednesday, just a few days ago, and this report specifically focused on women who died from cardiac disease in pregnancy, and I'm going to be describing some of the findings of this report. This is maternal mortality by cause in the UK, and I don't think that the population in the UK is so different from the population in Kuwait. And as you can see, cardiac disease is the #1 cause of maternal death in the UK these days, by quite some way. Reassuringly, anaesthesia is way down that list. Now, what were the causes, or the individual causes of cardiac deaths in the UK in this EMBRACE report? Well, these were confined to ischemic deaths, deaths from valvular heart disease, essential hypertension, myocardial disease, and deaths from sudden adult death syndrome, which I'm going to talk a little bit more about. And when you compare this to the CARPREG study, published, as I said, about 15 years ago, you can see a similar broad variation in the types of cardiac disease that can present to you on the labour ward. Now, I think at this point, I would just like to make one point. I think that no matter where you work, whether you work in a teaching hospital or a smaller hospital or a private hospital, I think you must never believe that, oh, this is not a problem that's relevant to me, because I think any pregnant patient can present to you on the labour ward or in the antenatal clinic with a cardiac problem that hasn't been detected previously. And you may be one of the first people to meet this lady and be charged with meeting the challenges of looking after her. So this is not specialist work that a general anaesthetist is never going to come across. This is relevant to you, whatever area you work in. Now, anaesthetic management, I think, encompasses various points. I think early involvement of the anaesthetist, because I think the anaesthetist these days can increasingly be a linchpin for any patient with other comorbidity, not just obstetric patients, but any patients. I think it's becoming clear that anaesthesia, the role, is really evolving into more of a perioperative role. And I think that I wonder about anaesthetists in 10 years' time, will we be called perioperative physicians? And I wonder about those people who choose to specialise in obstetric anaesthesia, will we be peri-obstetric physicians? Because the first thing that happens with a pregnant patient when they get sick is that the anaesthetist is called. And I think similarly, the first people that get called when a surgical patient becomes ill is the anaesthetist. And I think that our role is so much more than anaesthesia these days. So the first point I would stress is early involvement of the anaesthetist. This involvement must be maintained throughout pregnancy. We need to plan the type of anaesthesia at delivery. We need to make provision for care after delivery, and we need to have a plan B. Now, I think that every patient with a history of cardiac disease or a family history of cardiac disease, or perhaps a disease associated with cardiac manifestations such as Marfan's or Ehlers-Danlos needs early risk assessment. And this can really help you to decide how you're going to look after this patient and also where you're going to look after this patient. Now, risk assessment, this is the CARPREG score. This is the score that this study produced, and it really is a population-based score. And I have to say that it's quite a gross measure. But essentially, if you score more than one of those points, your risk of developing cardiac morbidity during pregnancy, they suggest, is greater than 75%. Now, I think perhaps a more useful assessment of a risk is the modified WHO classification of maternal cardiovascular risk. So this goes through all the classes that we're familiar with: mild, uncomplicated valvular lesions, patent ductus arteriosus being classed as low risk, up to class 4 in patients who have severe valvular stenosis or pulmonary arterial hypertension. And as you go up these classes, the requirement for cardiology input and specialist referral increases. But I have to say that just looking at that, even without looking at that, everyone has a common sense. You know that if you meet a patient who's got severe cardiac manifestations, you know that the cardiologists, perhaps the cardiac surgeons, are going to need to be involved. And for most of us, looking after patients with the extreme end of cardiac disease is really outside the remit of what we can do in our day-to-day practice. Now, one of the problems with cardiac disease in pregnancy is that the features of it, the clinical symptoms that you may see, fatigue, orthopnea, palpitations, peripheral edema, and murmurs, can also occur in normal pregnancy. So it can be very difficult to distinguish sometimes between normal pregnancy and a woman who's got worsening cardiac disease. The previous speaker did mention the increasing use of echocardiography in this area, and I would absolutely share his views. Transthoracic echo is something that's appearing more and more in anaesthetic journals. But one small point of caution I would make is that the gap between obtaining an image and making a therapeutic decision may be too great for somebody who is not used to using transthoracic echo. And I think particularly in pregnancy, where we know that the echo appearances of in a normal woman can change dramatically, I think making therapeutic decisions based on transthoracic echo in pregnancy really needs to be done by someone who's very experienced in this field. It may be an anaesthetist who's developed fantastic skills in transthoracic echo, but I think for many anaesthetists, including myself, my skills in transthoracic echo are currently very embryonic, and I would always seek the involvement of somebody who has greater skills in this area. Now, management during pregnancy, as I said, you need a lead clinician to coordinate care, and this, I think, can frequently be the anaesthetist. We can provide continuity of care. I think you need to decide what investigations and monitoring are required. We've mentioned echo. Fetal assessment, growth scans in particular. The first sign that a woman's cardiac disease may be worsening may be the fact that she's not perfusing the fetus as adequately as she should, and fetal growth may decline. So fetal growth scans are important as part of the assessment of the cardiac picture. In addition, these women may pass on their cardiac issues to their fetus, so the fetus needs to be assessed for that as well. Many of these women may be on cardiac medication, and we know that pregnancy alters the pharmacokinetic response to cardiac drugs, so doses may need to be altered in response to this. And also bear in mind that many of the agents can have an impact on the fetus, so some drugs may need to be changed for other less teratogenic agents. And also, lastly, just mention those women who are on long-term thromboprophylaxis. Again, this might need to be warfarin, as we know, is teratogenic, so these women will need to be converted to low molecular weight heparin, and also low molecular weight heparin doses increase in pregnancy, so standard doses may not be effective. Now, mode of delivery. This is some interesting data that's come from the ROPAC Registry, published just a couple of years ago now. They looked at mode of delivery in over 1,000 deliveries. They were a heterogeneous group of patients, so valvular disease, cardiomyopathies, ischemic heart disease. And what they found was that perinatal mortality and low APGAR scores were not significantly different. Gestational age and birth weights was lower in women delivered by caesarean section. But between the two groups, whether you were delivered by caesarean section or a vaginal delivery, there was no difference in maternal mortality, postpartum heart failure, or hemorrhage. So the author's conclusion was that vaginal delivery is the preferred mode of delivery for the most part. What about anaesthesia for these women? Well, neuraxial anaesthesia, as we have heard from the previous speaker, if there's no contraindication. And ideally, low-dose epidural, which has the least impact on cardiovascular dynamics, is preferred. A combined spinal epidural anaesthetic for caesarean section can be very useful, using a smaller spinal dose in the first instance and then extending the anaesthesia if the spinal dose does not provide adequate anaesthesia to provide an adequate level. And sometimes it's necessary to, if you want to do a vaginal delivery, it's necessary to induce labour to optimise the timing of delivery in relation to thromboprophylaxis. What you don't want is a woman coming in spontaneous labour who 2 hours ago had her dose of thromboprophylaxis, which would prevent you doing a low-dose epidural. Now, the third stage of labour is a very high-risk time for a woman with a cardiac disease. It's associated with very significant hemodynamic changes and fluid shifts. And one of the big issues around this time is the use of uterotonic drugs to prevent postpartum hemorrhage. And pretty much all of the or uterotonic drugs that we would use have some kind of cardiovascular effects. Ergometrin is probably the worst, and I would suggest to you that ergometrin should be avoided in these women. Oxytocin, if it's used, should be in a low dose, given slowly. And the standard in my institution is to use a 3-unit dose, but to give 1 unit every 5 minutes. An interesting drug that's appeared in the last few years is carboprost. Now, carboprost is a synthetic analogue of oxytocin, and it has, as we know, one of the biggest difficulties with oxytocin is that it has a short half-life, about 5 minutes, which necessitates giving it as an infusion. Carboprost has a much longer half-life, in the region of 3 to 4 hours. Studies suggest it has a similar cardiovascular profile to oxytocin, but it does have a much longer half-life. So I wonder if the use of carboprost may be beneficial in these patients, because it might avoid the use of additional uterotonics, such as ergometrin. But there's very little data on that at the moment. Now, one point I do want to mention is fluid balance in obstetrics. We think of these patients as young, as fit, and so that they can tolerate. We think of obstetric patients as young and fit, and people that can tolerate fluid loads. But even in the ordinary parturient, one without cardiac disease, there are significant problems with fluid balance. Pregnancy is a volume overloaded state. Coexisting disease such as preeclampsia can make the risks of volume overload increase. Drugs such as syntocinon or the prostaglandins used to manage hemorrhage can further increase the risk of volume overload. And I think that we are reticent to use additional monitoring in these patients because of our perhaps fixed belief that mostly they'll be fine. We're probably less aggressive about instituting additional monitoring to monitor their fluid status than we would be in a patient, say, having a laparotomy. So I think that we, as a community of specialists, we do need to lower our threshold and perhaps be more aggressive about instituting additional monitoring in these patients. Now, I just want to briefly describe some findings from the confidential inquiry which was published 4 days ago, and I'm going to talk about ischemic deaths. We've changed the formatting of my slides, so it's moved a little bit, but I'm going to talk about SADS and cardiomyopathy as well. So first of all, aortic dissection. Now, aortic dissection has a 25-fold increased risk in pregnancy. And it has a very high mortality with a poor surgical outcome, especially, as I said, especially in pregnancy. Mostly, aortic dissection occurs in late pregnancy or the puerperium. Now, this is a vignette from the confidential inquiry which describes some of these points very nicely. A woman in her 3rd trimester was admitted to the obstetric ward with severe chest pain that required opioid analgesia. She was an inpatient for 3 days, during which time myocardial and ischemia, pulmonary embolism were excluded. She continued to need opiates for her severe intermittent chest pain. Eventually, she was sent home, where she died at home. She collapsed and could not be resuscitated. And the post-mortem showed extensive ascending aortic dissection with hemopericardium. Now, I think when a pregnant woman presents to you with chest pain, I think the first thought of any clinician is pulmonary embolus, pulmonary embolus, pulmonary embolus. And I think increasingly we're starting to think, well, it could be ischemic disease as well. But I think that it's not simply enough to exclude pulmonary embolus or ischemic pain. If a woman is requiring opioid analgesia to relieve her chest pain, there must be very significant pathology going on here. And I think just to send a patient home without a definitive diagnosis is cavalier in the extreme. The next case, an obese multiparas patient was hypertensive in late pregnancy. She was delivered at home by emergency cesarean section. She was hypertensive post-delivery and discharged home on labetalol. A week later, she developed severe back pain associated with incontinence and leg numbness and paralysis with marked hypertension. She had cold mottled peripheries. Cauda-Equina syndrome was considered but excluded by MRI. No further attempt was made to make a positive diagnosis until several hours later when she collapsed with hypotension and profound metabolic acidosis. An urgent CT scan was planned, but it didn't take place for a further 2 hours, by which time she was in extremis. When the CT scan was done, it showed dissection of the whole descending aorta, and although she was transferred to a regional centre, she sadly died. Now, I think this case demonstrates very nicely a point that I want to make. Increasingly in medicine, we hear about the role of human factors, and one of the aspects of human factors is fixation error. Now, when a woman presents with hypertension, we think that or neurological signs. When a woman presents with neurological signs, as anaesthetists, we're thinking a problem with the spinal cord, Cauda-Equina syndrome, and we don't think outside the box. And I think this represents a clear example of fixation error. A fixation error occurs when a practitioner concentrates solely upon a single aspect of a case to the detriment of other more relevant aspects. And we know that it can delay diagnosis. And it can also stop us changing a management plan from plan A to plan B when plan A fails. Now, fixation errors have been implicated in a whole host of medical disasters over the year. The most recent one I can remember in my own hospital a few years ago was an obstetric patient who was tachycardic post-delivery. Her tachycardia increased and increased and increased, and she was diagnosed with an SVT. And the people involved did ECGs and called cardiologists. But they didn't look at the whole patient, and they didn't look outside the box. And of course, she didn't have an SVT, she was actually bleeding. So I think that we've got to be prepared to consider other diagnoses. It's very easy just to dismiss neurological symptoms in an obstetric patient as something related to the spinal cord. But cardiovascular problems can also present with neurological problems. And I think the other point I want to make is that as anaesthetists, we're always taught to have a plan B, when things go wrong. But there's no point in having a plan B if we don't have a willingness to change to that plan B when things go wrong. Now, sudden adult death syndrome with a morphologically normal heart. Now, this is an emerging entity where people, usually young people, collapsed from cardiac arrest. And you're probably wondering why I'm mentioning it to you, because as an anaesthetist there would seem to be little that we can do about it, and that's true, but there is one aspect I think that has some relevance. This seems to be increasing in prevalence. This is data from the UK, which shows, you can see that over the last 10 years or so, there's been a huge increase in the number of women who've died from this complaint. But I want to point out that this is not because the death rate is actually increased. It's much more likely to be due to the fact that we're actually detecting these women and they're getting the right post-mortem diagnosis. Now, the post-mortem diagnosis is important because many of these can be related to congenital genetic factors. And if a woman dies and has a PM and the PM diagnosis is sudden adult death syndrome, the woman's family must be referred for testing. But the reason I want to mention it to you as an anaesthetic and internists is this case report. A young woman from North Africa had a cardiac arrest during labour. Chest compressions and manual ventilation were commenced, but no attempt was made to ascertain her cardiac rhythm. She was moved to theatre for a perimortem C-section. She was intubated and the baby delivered before defibrillator pads were attached. She was in VF. Now, if you're going to reverse a cardiac arrest situation, VF is I don't want to say easiest, but it's the one most amenable to reversal. Despite multiple shocks and prolonged resuscitation attempts, she could not be resuscitated. So the point I want to make to you is that if you are ever in this dreadful situation, early defibrillation is of the utmost importance, and each minute that you delay defibrillation reduces the likelihood of survival. And I think in this situation, the overwhelming desire is to do a perimortem caesarean section. And I think that, we think, well, let's try and at least save the baby. But remember, you're doing a perimortem caesarean section in that situation, not primarily to save the baby, but primarily to try and improve the mother's chances of resuscitation. But there's no point in doing that if you're forgetting a very, very important part of resuscitation, and that's defibrillation. Now, maternal cardiac arrest is a very topical subject. There's lots of work coming out about it at the moment. And I just want to tell you about this very nice study. This is it's a simulation study that comes from America, and what they did was they looked at 26 teams of 2 providers doing managing maternal cardiac arrest situation. And they had a primary outcome of the percentage of correctly delivered chest compressions, and a secondary outcome of looking at the number of interruptions in chest compressions, because we know that chest compressions is a key part of resuscitation. So what they did was they, in one group, they kept the patient, they did resuscitation and the perimortem caesarean section where the arrest occurred. And in the another group, they decided to move the situation from the labour room to the operating theatre. And what they found, unsurprisingly, was that in the stationary group, where resuscitation and perimortem caesarean section was carried out in the same place, the percentage of correctly delivered chest compressions was much greater than in the group that was moved. Similarly, the number of interruptions in chest compression, you want continuous chest compressions, you don't want to interrupt, it was much lower in the stationary group. So I think the take-home message here, and something I think you should take back to your own units, is that if you are in that dreadful situation of having to perform resuscitation on a pregnant woman and do a caesarean section, you should be prepared to do it there and then. And I would urge you to consider developing emergency caesarean section packs that you can bring to the patient rather than bringing the patient to theatre. Now, just to finish off, I just want to mention ischemic cardiac disease in pregnancy. Now, depending on what case series you look at, this seems to have quite a variable incidence. A study from America suggests an incidence of 3 to 6.2 per 100,000 deliveries, but in the UK, a more recent incidence suggests it's much lower than this. Now, these are the risk factors for cardiac disease. Now, if you look at these, older age, perhaps not smoking in Kuwait, but all of these other factors, these are increasingly prevalent in all of our obstetric patients. So I think that we shouldn't for 1 minute think that our obstetric patients aren't at risk of ischemic cardiac disease. An older woman had an uneventful pregnancy until 34 weeks when she developed chest pain. The pain was on and off for 3 days and radiated to her back and left arm. She was a smoker and had a family history of cardiac disease and hypertension. She was called an ambulance and she was given Entonox by the ambulance man. And when she was assessed in the emergency department, no one asked about her risk factors for cardiac disease. Despite an abnormal ECG, which they attributed to her being pregnant, she was discharged and she was found dead in bed at home a few days later. And I think that we really need to, up there with pulmonary embolism, we used to consider that our number 1 cause of chest pain in the obstetric patient. I think we need to give it equal billing, the risk of myocardial ischemia. So just to summarise, cardiac disease in pregnancy does represent an extremely heterogeneous group of conditions. Current management strategies that we have are largely generalised based on population studies, and we really need to individualise our management. We need multidisciplinary teamwork required to ensure good outcomes, and the anaesthetist, I believe, should be involved at an early stage in our increasing role as peri-obstetric physicians. Thank you.
Thank you very much. Professor Young, please. If any questions? دكتورة هدى.
Thank you very much again for brilliant lectures. Really enjoyed that. I have a question regarding the frequency of antepartum echocardiography. How often would you do that? Especially considering what you said, Professor Yang, about the highest risk being at the end of the second trimester and beginning of the third. So if they had an echo at that time, would you not repeat it till term? Or what would you recommend?
I'll take the first crack at it. Certainly, that's why I showed you the slide about echocardiographic abnormalities, if you want to put it in quotation. In normal pregnancy, patients will exhibit valvular regurgitations, for example. And so when we do a lot of echo, I sort of go back to what I was saying yesterday. For every test, we have properties such as the sensitivity, specificity, the receiver operating curve. Not every test is innocuous, because once we find something abnormal or potentially abnormal, we have to chase it down. And we have lots and lots of examples and studies to show in chasing down these, quote, false positives, patients have come to harm. So we have to be really going back to what is the likelihood, what is the prevalence of disease in the population that we're doing the test on. So if we're doing the echo and there was a good indication initially, then yes, absolutely it makes sense to follow up during the end of second trimester to see how things are going on. But I am not advocating doing echo on everybody who walks through the door. And I would also support very strongly what Dr. Lucas said earlier. The echo is not for someone who takes a weekend course and then goes out and tries to make therapeutic decisions and diagnostic decisions. It really has to be someone who is well trained